Welcome, everyone. My name is Sarah Meyer, and I am a member of the HEAL Data Stewardship Group. Thank you all for joining us today for the 20th installment in our Fresh Fair webinar series, Advancing Open Science with the HEAL Data Ecosystem. Could you please go to the next slide? Today's webinar will feature a presentation introducing open science, followed by lightning talks from researchers detailing their experiences reusing or synthesizing data to inform on-the-ground work, decisions, and policies. Next, the HEAL Stewards and the Data Connections team will describe how each team helps investigators open data science, practice open science, both within and beyond the HEAL data ecosystem. This webinar is being recorded and will be shared with all registrants. If at any point you have a question, please feel free to type it into the Q&A box at the bottom of your screen, and we will bring it up during the Q&A section. Next slide, please. Today we are joined by our presenters, Dr. Jessica Mazerik, Dr. Sarah Woods, Dr. Rachel Wightman, Liezl May Foss, and Jennifer Cook. We will also be including Jen Farfalla in our Q&A session. Our first presenter today is Jessica Mazerik. Next slide. Dr. Mazerik is the program director for the HEAL data ecosystem. Prior to working in the HEAL Initiative, she led workforce activities in the ODDPCPSI Office of Data Science Strategy and served as a special assistant to the NIH Deputy Director, where she focused on artificial intelligence and data science, among other activities. She coordinated 2 prize competitions to develop 3-dimensional retinal tissue models for the National Eye Institute Office of the Director. I will pass it over to Dr. Mazerik for her presentation.
Yeah, so you're going to hear 2 real-life stories today from researchers practicing open science principles to address a public health emergency. Their stories are going to highlight the significance of disseminating data and results to the research community and also beyond. And we hope that you'll walk away from today inspired to integrate with the HEAL data ecosystem, infrastructure, and support teams to really maximize the impact of your research as well. Why do we care about open science as a research community? Well, think about a world where every research paper, information about every finding, and scientific experiment is available for anyone to see, where any budding scientist, irrespective of their location or affiliation, can access, learn, and build upon existing knowledge. Open science really democratizes knowledge. By making research and methodologies and findings open, we eliminate redundancies of repeating experiments. This not only saves time and resources, but it accelerates the pace of discoveries. Open methodology and data also helps to ensure reproducibility, so other researchers can validate and build trust in the findings that are out there. Sharing findable, interoperable, accessible, and reusable data is critical because it fuels scientific discovery, fosters fresh insights, and leads to more robust outcomes. Overall, it maximizes the quality of science. And data sharing promotes collaboration and enables different groups to come together, bring different perspectives, and leads to multidisciplinary innovations and solutions. Next slide. Yeah, thanks. Why is open science important beyond the research community? Well, it promotes transparency and it helps build trust amongst communities and stakeholders. And this is particularly important in sensitive areas working with data such as healthcare data or working in public policy. When data results and information are easy to find and access, it helps to avoid duplicated efforts. And open science also helps engage the public and other stakeholders in research and decision-making processes. And this can lead to really better informed decisions, increased public support for various initiatives, and it can also lead to unexpected discoveries and benefits for the broader community. And as science becomes more open, the general public can be informed, engaged, and participate in the scientific process to really help bridge that gap between scientists and society. So now that I've convinced you all that open science is very important, I'll hand it back to Sarah to introduce our first speaker, Dr. Sarah Woods, to tell us about her team's work using publicly accessible data for secondary analysis.
Thank you, Dr. Mazerik. Dr. Sarah Woods is an associate professor and vice chair of research in the Department of Family and Community Medicine at UT Southwestern Medical Center. She is a licensed marriage and family therapist and studies how family relationships get under our skin to impact our physical health. Her current research focuses on explicating psychophysiological stress mechanisms of effect and integrated behavioral health interventions. I'll pass it to Dr. Woods for her presentation.
Thank you so much for that lovely introduction. And we can do next slide. So our team's aim is to understand direct and indirect links between family relationship quality and chronic pain outcomes, specifically for aging African Americans. So although previous research has identified these pathways for predominantly white samples, and older African Americans repeatedly share in qualitative research that high quality supportive relationships with family are critical to pain management. It's still unclear how family relationships may predict pain outcomes for this particular population, which then of course compromises our ability to know where and how exactly to intervene. So our team is leveraging 2 longitudinal studies of aging health and their publicly available data sets to test family pain pathways. Both of these studies are supported by NIH and available through University of Michigan's Institute for Social Research. So the first data set you see here is the Midlife in the United States project. We are using the second and third waves of what's referred to as MIDAS, which expanded the diversity of its initial baseline sample, which included over 7,000 Americans, through an intentional sampling procedure, resulting in their Milwaukee-based sub-projects at that second wave. So the advantage of this data set for our work is it includes really rich pain-related measures, including pain interference and pain-related diagnoses. The second data set that you see here is the Health and Retirement Study, which is a longitudinal panel study of about 20,000 Americans beginning in the early 90s. We are specifically using waves from HRS that are contemporaneous with MIDAS 2 and MIDAS 3. So the structure of our work is that we first test each of our models with MIDAS data, and then we replicate these tests using HRS data. So while both data sets use the same measures to assess support and strain in intimate partner and family relationships, one advantage of HRS is it also uses these same support and strain measures to assess aging African Americans' relationships with their adult children, which is a really important relationship, of course, as we age. So HRS is also has the advantage of being a larger sample. It's also an older sample, given the project includes adults 55 and older, and also surveys participants every 2 years versus the 10-year waves of MIDAS. So to highlight benefits of why 2 data sets, I'm going to share some of our initial AIM-1 tests of direct effects between family relationship quality and specifically pain incidence and pain persistence. Next slide, please. Thank you. So along with testing each of the observed strain and support variables in each type of relationship, we also tested models using support and strain within relationship types. And we created support and strain indices, which meant that we averaged support and average strain separately across each relationship that a participant was a part of to be able to capture average support and average strain experienced in all relationships for each participant. So in our tests of pain incidence, we found among MIDAS participants that family support, but also our average support index, each were tied to decreased risks of pain incidence. So this is our subsample of MIDAS participants and HRS participants, which I'll talk about in a moment, that were reporting no chronic pain at baseline. So we also found evidence for the benefits of family support and average support in our tests of pain persistence. In fact, until we average support across all of HRS participants' relationships, the observed variables were not tied to persistence, which is a really sort of unique and interesting finding. And then further, when we replicated and extended our models to test pain incidence in HRS, we found a unique result where parent-child strain, as well as participants' average strain across all the relationships they were a part of, was linked to an increased risk of new chronic pain developing over the following 10 years. So it's possible it's because the HRS participants are older. It's also possible that they may have greater caregiving needs as a result. And it's also possible, of course, that these pathways are reciprocal over time, which we'll also be able to test with these data sets. So each of these projects and their unique advantages will allow us next to test, for example, the timing of pain outcomes longitudinally, as well as to explore unique biobehavioral mechanisms of effect that help explain how family relationships may be linked to pain. And we're also really excited that these preliminary AIM-1 results that you see here are really very consistent with what older African Americans living with chronic pain have often shared that they need to be able to manage their pain effectively in other research projects, which is specifically family support. And so we're really hoping that our work will help inform how pain treatment can be decided collaboratively with patients and family, but also how we can meaningfully leverage the healing power of family relationships to improve pain outcomes. I'll pass it back to you, Sarah.
Thank you. I would like to introduce our next presenter, Dr. Rachel Wightman. Dr. Wightman is an associate professor of emergency medicine and epidemiology at Alpert Medical School of Brown University. She is triple board certified in medical toxicology, emergency medicine, and addiction medicine. She serves as the director of toxicology and addiction medicine for Brown Emergency Medicine and a consultant medical director at the Rhode Island Department of Health. Her research interests are emerging drug use patterns, evaluation of toxicology testing results, and medication management of opioid use disorder. She co-founded the Rhode Island Buprenorphine Hotline, a statewide telehealth low-threshold buprenorphine treatment access line in partnership with the Rhode Island Department of Health and the Rhode Island Department of Behavioral Healthcare Developmental Disabilities and Hospitals, which was funded by SAMHSA. I'll pass it to Dr. Wightman for her presentation.
Thanks so much for that introduction. We can go ahead and even move to the next slide. It would be great. So the study that I'm going to present today was funded by the Foundation of Opioid Response Efforts. You can go ahead and move forward. So I'm going to talk about a study that we've been conducting over the last 2 years. My co-PI is listed here, Dr. Alexandra Collins. And the overall goal of this study is to build a local drug supply, surveillance, and rapid data dissemination system. And kind of the background for why we thought that this study was needed and this type of system would be needed is that a lot of advanced toxicology testing of the drug supply or biosurveillance testing is done in silos. So if you think about the sources that are traditionally used, it's postmortem toxicology testing, drug seizure data, and often academic labs or reference labs. And unfortunately, that data is rarely shared in a timely manner. It's often reported when it is at very high level, so omitting things such as active cut or combinations of drugs, and very rarely communicated back to the local community in a timely or actionable way. And so kind of the add to that is that tox data is often analyzed in a bit of a vacuum, so away from the context of local use practices. So for our study, we really sought to not only combine advanced toxicology testing methods of the local drug supply using anonymous drug sample testing, but marry that with the listening piece. And the goal of the listening piece was to really understand and speak with people who are using substances to understand how changes in the drug supply were impacting their health and how they're actually using substances, including things like prep practices or instrumental use. And we felt that having those two data elements tied together was really essential to interpret any tox testing data and develop harm reduction messaging. So the other part of the study was our community advisory board. And so the community advisory board was embedded from the beginning of the study to really help us make sure that our data was transparent and accessible. And the community advisory board for this study was made up of on-the-ground substance use treatment workers, outreach and harm reduction workers in our local community, partners at the Rhode Island Department of Health, and people who are actively using substances or had previously used substances. And in addition to having that CAB element, we also partnered closely with the Rhode Island Department of Health and local community outreach organizations. And we kind of hooked into those existing data channels and dissemination pathways because we thought that that was essential to make sure that our data didn't get siloed, that it was kind of built in and worked into existing data streams and infrastructure and the way things were shared with our local community in order to be able to reach a broader audience with the goal of reaching the public, healthcare providers, outreach workers, and people who are actively using. And so I'm going to go ahead and just kind of run through how an example case, and we'll use xylazine, of how we took data found and kind of worked through the system to create messaging. And I want to highlight, though, before we jump into the xylazine portion, that we found a lot more than just xylazine in our testing. We found nitazines, we found synthetic cathinones, synthetic cannabinoids, novel benzos. And so this is just kind of one example of the workflow for a finding in the study. So when we started the study, there had been no drug sample result of xylazine reported in Rhode Island. We knew that it was being seen in Philadelphia and that our neighbor, Massachusetts, they had had drug sample testing that was positive for xylazine, but it was kind of the first time that it was seen in Rhode Island. And we started in May 2022, and we pretty much immediately started finding xylazine. And as you can see, this is an early tally of some of our first samples, but the majority of the samples that were sold as fentanyl had xylazine present. And we knew from not only kind of our on-the-ground listening work, but with discussions with our CAB and healthcare providers that nobody had really ever heard of xylazine in our local community. Nobody knew it was here, but we were able, through that listening and ethnographic portion of the grant, to talk with people and figure out what they had been experiencing. And a lot of those experience reports matched up with what was being reported in other areas where xylazine had been detected. So things like prolonged, profound sedation, ongoing sedation after naloxone reversal of overdose, and increased wounds. And so we brought these data elements of what we were seeing and hearing on the ground to the Rhode Island Department of Health, and they were able to arrange a bunch of multidisciplinary meetings around this study finding, which was pretty amazing and exciting to have happen at the state level. And we met with teams and presented at Governor's Overdose Task Force and a lot of different venues to really start these discussions. And what came out of them was messaging, which I'll show you kind of some of what the messaging looked like. But I feel like the more important things of these conversations was action steps that came out of them. So we realized that the overdose trainings that had been ongoing in our state were really not targeted or applicable necessarily, or accounting for polysubstance overdose. And so the actual trainings for overdose were updated to include management for polysubstance overdose. Additional things that were highlighted was the increased prevalence of wounds and need for additional wound care resources, especially wound care resources that would be sensitive to populations that were using substances. And so at the state level, the state actually funded a wound care nurse to go out with our outreach teams and provide wound care support and triage in the field to people who are using substances. And then another example, just kind of through those conversations, it became readily apparent that wounds were also a barrier to get into our local shelters, residential substance use treatment. And so the state actually funded beds in a medical respite dedicated to wounds and wound care, and to increase access. All right, we can go to the next slide. So those are some of kind of the action points, and these are some of our outputs. And if you go to testri.org, you can see all of our sample testing results. We have supply updates, we have spotlights, kind of highlighting specific samples that were found or specific substances. But this were some of the additional messaging that we did around xylazine, for example, palm cards. The one, I guess, on the right here is a palm card that was put out by the Rhode Island Department of Health. And then on the left, you can see a social media campaign by Rhode Island Department of Health that promoted our xylazine, which was another way that we were sharing information about xylazine. I'm not really sure about this photo. They married it with our Governor McKee photo. I'm not actually sure what he's signing there. We can go to the next page. And because we were tuned in with the dissemination data dissemination channels that were already existing within the Rhode Island Department of Health, we were able to send provider advisories out to pretty much anybody with a healthcare license in Rhode Island. And so you can see here just one example of one of many provider advisories that we sent out. This one was specifically about nitazines. And I know that my colleague, Dr. Collins, who's the co-PI on the study, is going to present a lot more on the data dissemination piece of this study, including the social media aspects. And thank you so much for listening.
Okay, let's see if we can do it this time without any audio glitches. Thank you so much to our two wonderful presenters. Sarah and Rachel have told us really inspiring stories about how access to data and results can shape future discoveries and changes in outreach, practice, and policy. So to support HEAL researchers in practicing sharing data and translating results beyond the research community, we put in place the HEAL data ecosystem. For the past 2 years, we've been building technical infrastructure, HEAL data platforms, semantic search, and other tools, and had major focus on helping HEAL investigators share their data. Many of you have heard about these efforts in past Fresh Fair webinars or otherwise, probably. But last year, we brought on HEAL Connections into the ecosystem to work with HEAL investigators to take sharing of data and results a step further. Connections collaborates across various groups to translate findings into meaningful products for and with input from communities and stakeholders. So during the remainder of the talk, you're going to hear about the tools we're developing to share information and data and provide transparency. And you'll also hear from the teams about support they provide to HEAL researchers throughout the lifetime of your awards as you're getting started with your research product, conducting your study and collecting data, and sharing your data and publishing. Back to you, Sarah.
Thank you, Dr. Mazerik. Our next presenter is Liezl May-Foss. Liezl May-Foss is a HEAL steward in the data management group at RENC. Liezl has 5 years of experience working in both industry-led and academia-focused clinical research trials. Working previously for a large contract research organization, she was involved in the management of several study sites within a given trial, ensuring that proper documentation and clinical procedures were followed. As a clinical research coordinator for a medical university, Liezl worked closely with the PIs to ensure that study visits and other study-related tasks ran smoothly and efficiently. As a HEAL steward, Liezl integrates her background to support investigators in the HEAL ecosystem by providing guidance and strategy for data management.
Thank you, Sarah. So the NIH HEAL Initiative has funded a significant number of research studies, creating a comprehensive, vast information pool ripe for groundbreaking discoveries in pain and substance use disorder research, paving the way for innovative treatments. However, the challenge lies in effectively navigating this extensive and diverse set of data, a task complicated by the variety of research methodologies and data types involved. So to further solidify the HEAL Initiative's efforts to practice open science, I'll be talking about two different infrastructures or tools that support this open science philosophy. So first, I'll talk about the HEAL data platform. And given the diversity of HEAL studies in terms of field disciplines and the varied repositories that HEAL studies will deposit their data into, it's essential to have a cohesive system. And as you see here on the screen, the HEAL data platform bridges this gap, connecting over 800 studies data from over 20 recommended repositories under the guidance of the HEAL Initiative. With the vast range of data types and studies, a single centralized repository isn't feasible. So as a solution, the HEAL data ecosystem spans over 20 HEAL compliant repositories. It's important to note that the HEAL platform isn't a data storage system. Rather, it operates as a portal that aggregates information from pre-existing repositories. So think of the HEAL data platform as a catalog, functioning as a comprehensive index that enables researchers to efficiently locate and access the data they need. And by serving as a centralized reference point, the HEAL data platform simplifies the navigation of the data landscape, promoting greater collaboration and enabling a deeper understanding of complex health issues. I believe my colleague pasted the link to the HEAL data platform in the chat, so that's available to you if you would like to take a look at it later. Next slide, please. The HEAL data platform is complemented by the HEAL semantic search tool. I'll also be referring to this as HSS. The HEAL semantic search tool is designed to streamline this process utilizing advanced semantic technologies to facilitate the exploration of this rich data set landscape. The HEAL semantic search revolutionizes the way you explore the HEAL research landscape by leveraging concept knowledge, synonyms, and intricate relationships. As a user, you're not constrained to precise keywords or direct data access. With our HEAL semantic search, you can uncover related biomedical concepts, studies, and variables. You can pinpoint specific data sets and variables for in-depth analysis. In essence, this tool simplifies and enriches your data exploration journey, making it both intuitive and comprehensive. And again, my colleague will provide the link to this tool and also a recording of a webinar that the Fresh Fair seminar series did, containing more information about the HEAL semantic search engine. And if there is a key theme I'd like to highlight, it is that metadata is the powerhouse behind the HEAL platform and HEAL semantic search. By leveraging metadata that investigators provide, we're able to enhance searchability and integration of diverse data sets, broadening research impact and fostering collaboration. So I'll be shifting gears and would like to highlight that interpreting and disseminating data holds significance that extends beyond our research community. It's not just about journals or conferences, it's about empowering the public with this critical information, ensuring that they are informed and engaged. So up next, I'd like to introduce Jennifer Cook, MPH, from the HEAL Connections team. She will elucidate on the essence of meaningful data sharing that resonates beyond just our scientific spheres. Jennifer is an associate director in the Research Communications and Engagement team at the Duke Clinical Research Institute within the Duke School of Medicine, and a project leader for the HEAL Connections team. She brings more than 25 years of experience in healthcare communications and has a Master of Science in Public Health from UNC Chapel Hill and deep experience with patient and community engagement in academic publications that have been cited extensively. So I will now turn the floor over to Jennifer.
Thank you so much, Liezl, and thank you so much for including HEAL Connections today in this fantastic presentation. I'm going to spend about the next 10 minutes telling you about HEAL Connections, what it is, and how this infrastructure can hopefully help you in meaningfully sharing research results. HEAL Connections was created to enable HEAL's vision to make research results useful for communities, which is the name of the game today in this presentation. But to make research useful, we first need to understand community needs, build bidirectional partnerships between researchers and communities, and make research results understandable, accessible, and user-friendly. And that's where HEAL Connections comes in. If you go to the next slide, you'll see that to help, HEAL Connections is actively building and extending relationships in 6 core areas of focus. We're looking at partners that are in community-based organizations, health organizations, patient advocacy, priority populations, state, tribal, local, and federal government, as well as criminal justice. Our framework for community engagement with these partners is built off of existing successful models from other HEAL Initiative projects, such as the Justice Community Opioid Innovation Network, JCOIN. This framework is intended to foster bidirectional partnerships between HEAL research teams and intended stakeholder groups and beneficiaries to help broaden the reach and impact of HEAL research results. So we're interested in what researchers want to share with communities, but we're equally interested in what communities want to know more about. If you go to the next slide, I'll tell you about some of the things HEAL Connections, the HEAL Connections team is doing right now. First, as we discussed, we have active partnerships in priority areas with an eye toward building more. Next, we offer dissemination services where we work with research teams and their project leadership in the NIH to develop communications products to share their research findings. We also offer training, office hours, and we collate resources to help build research team capacity to disseminate and engage themselves. In fact, we have a webinar coming up that I think is in the chat next month on creating plain language materials, and I encourage everyone to sign up for that. If you go to the next slide, I'll give you a little bit of a case example of what we talk about when we talk about what sort of dissemination support we offer. So one of the first HEAL projects we supported was the Eat, Sleep, Console study, ESC, which you may be familiar with. This study looked at whether the Eat, Sleep, Console approach to partnering with parents and caregivers of newborns with who were born with neonatal opioid withdrawal syndrome, called NOWS, if working with them to monitor symptoms could safely and effectively improve the function and comfort of newborns with NOWS compared to the traditional approaches that were used. This study results indicated that newborns cared for with this ESC approach were medically ready for discharge 6.6 days earlier, and they were 63% less likely to need medication for treatment compared to newborns cared using the traditional approach. So these results were really impactful. At 3 months, infants treated with the ESC approach showed no significant differences in safety outcomes compared to those treated with a traditional approach. So this research, if you go to the next slide, it was really exciting for a number of stakeholders that work with pregnant people. And I'll tell you how HEAL Connections helped get the word out. First, we held dissemination planning meetings with NIH and study leadership to identify needs and brainstorm ways that HEAL Connections might be able to help. Next, we engaged with these stakeholder partners that I told you about earlier to assess their interest in partnering to disseminate the news through their own social media channels and blog posts and newsletters and emails. Then we co-developed a dissemination toolkit working with the NIH communicators as well as the stakeholders themselves to identify what would be most useful to those partners when they were disseminating this news, including social media cards, newsletter copy, and other products. We then shared what we created with a rapid feedback team so we could get stakeholder insights prior to distributing the materials. We then shared the results via those association partners and their wider dissemination networks. But we also identified a gap. Talking to the investigators, we realized that there was a need for interim advice to people who were curious on how to get started in implementing this approach in their own hospital or care facility if they hadn't already. So we've been working on a brief executive summary that helps package up some of the key questions that folks need to ask, the steps that they'll need to take, and the resources that are available to help get them started on their path towards implementation. If you go to the next slide, you can just see some images here of these products we're talking about, including graphics, videos, and social media. So if you go to the next slide, I'll just conclude by saying that in any of the projects that we want to serve, these are sort of the three basic steps we're going to take. We're going to meet with research teams and the NIH leadership and program officers that help them. Then we're going to tailor products that are needed and results for the stakeholders that are interested in learning more about the research results, so that we can achieve this wider dissemination. And then if appropriate, we're going to be thinking about these larger products that help put research results on a path towards implementation. And that is HEAL Connections in a nutshell. Oh, next slide. Actually, as I mentioned, coming soon, we offer these webinars to help showcase dissemination and engagement success stories and encourage skill building. So we want projects to learn from each other. Our next session is on December 7th. It's super exciting, communicating your research with plain language materials. And we're going to be featuring Test RI as well. So stay tuned, you can learn even more. The HEAL Connections sharing session will feature presentations from researchers and partners who successfully transformed results into a variety of multimedia formats, including one-pagers, videos, infographics, and zines. So please register for that. Again, thank you so much for including HEAL Connections today. And I think it's time to wrap up and make some time for questions.
Thank you so much for the presentations, Dr. Mazerik, Dr. Woods, Dr. Wightman, Liezl May-Foss, and Jennifer Cook. The NIH has introduced open science and its importance in HEAL. Lightning talks showcased real research involving data reuse or synthesis to impact communities. The HEAL Stewards presented the HEAL data platform and HEAL semantic search as tools supporting open science, and HEAL Connections emphasized the importance of making research results and data accessible to a variety of communities. The call for action for this audience is to utilize these resources and best practices to engage in meaningful data sharing to impact real lives. Before we open up Q&A to all of our Q&A panelists, I would like to introduce one panelist who we're inviting to Q&A. Jen Farfalla is the Director of Overdose Surveillance and Prevention at the Association of State and Territorial Health Officials, known as ASTO. ASTO works with state health officials and their agencies to support and enhance their jurisdictions' public health programs and services. Jen leads a team at ASTO in supporting health agencies who are recipients of CDC's Overdose Data to Action Cooperative Agreement, a funding mechanism to improve state and local overdose surveillance systems and to use that data for preventative action. Jen and her team provide technical assistance and capacity building to these jurisdictions to increase data-driven naloxone distribution, use data to identify and address inequities in overdose, and design overdose prevention programs to fit the needs in that particular jurisdiction. If all of our panelists could please turn on their cameras, we will now stop screen sharing and begin the Q&A session. So question number one, in leveraging secondary data, can you talk through some of the challenges you have encountered in data documentation, quality, and inconsistency? Do you have recommendations for actions investigators can take to enhance their ability of other investigators to use their data in secondary use? Dr. Wightman or Dr. Woods, would you like to start? And then I'll open it to other panelists.
Sure, I'm happy to jump in on that. So not with Test RI, because that was our own data generated, but I've done previous secondary analysis on Stewards data. And when going through that data, I can say the most important thing was really speaking with the state epidemiologists that were doing the data entry, and speaking with our forensic toxicology laboratory to really understand how the data was generated that went into the database. So kind of doing that background research can be really helpful to make sure that you really understand the data, because sometimes Stewards is postmortem toxicology testing. It's a state database, but it's national. I think there are 36 states that now have Stewards data run by the CDC. And using that data, you can get a lot of insight, but unless you know what testing was done by the medical examiners in the forensic lab over what period of time, it's really hard to know how to interpret the data you're seeing, at least for toxicology testing. And so kind of doing your background homework and talking with the people that generate the data is, I think, the most important thing.
I think if I could maybe speak to the second question about recommendations for investigators in terms of sharing your work, I will say the two data sets that I described using here today are both extremely clean and user-friendly, which is so fantastic for people like myself who are not directly affiliated with the original project, right? I'm using it as secondary data. So I think clean, clear code books are really, really key, including like really very specific sources for methods, instruments, as well as the specifics of the study protocol that helps other researchers contextualize the work in as clear and approachable language as possible, right? Because I think a lot of the value of open science happens through accessibility and transparency. And I think these two data sets are really great examples of that helped us very early on identify where there was overlap and also where there were maybe some differences that we had to then decide how to either rectify for consistency or test using different psychometrics, right? So I think as clean and clear as you can make that so it's approachable for other people, it's really, really super helpful.
Do any of our other panelists have other comments on this question? Okay, we will move on to question number 2. What advice can you give to researchers who are thinking of utilizing data sets from private or administrative sources to conduct a similar analysis? Liezl, would you like to start and then we can open it to the rest of the panel?
I'm afraid I won't really have much input on advice I can give researchers who are utilizing data sets that are from private or administrative sources. I was wondering if Dr. Woods, if the data set you were using, did it come from a private source? Did you have to get special requirements? And if so, what were the hurdles or anything that you could give advice to young investigators also pursuing the route of?
Sure. Yeah. So both of these data sets happen to be available through University of Michigan has an Institute of Social Research, and their ICPSR group houses the MIDAS data, for example. So it's a data repository. It's not the HEAL data repository. It's just where these projects were housed. And so some of the data within these projects does require special extra permissions. So I think planning for that phase when you need to request permission to use some of the data is really important, because that, in my experience, that didn't necessarily take a long time, but it is a step that you have to go through. And sometimes, of course, that may also require like data use agreements across institutions. And in my experience, that piece can vary in terms of time, in terms of when legal is involved, sort of having those communications across institutions. But in general, I think, so yes, MIDAS and HRS required additional permission for like the Milwaukee subsample that I talked about, and for some of the biomarker data, for example. That was easy for these projects. Pardon me, it isn't always. So I think planning ahead to know which piece of the data you may need extra permission for, and then to also consult with compliance, legal, those pieces, just to make sure you have your boxes checked and you're planning for that part of your timeline.
And to add to that, I'm really lucky in Rhode Island that we have access to a ton of different administrative databases, things like EMS overdose, ED visits for overdose, PDMP, and we recently completed a secondary analysis study using PDMP data to look at buprenorphine prescribing, and just kind of thinking through the steps involved, just making sure that you have all the IRBs lined up, because when you're crossing institutions, I not only have to get an IRB from Lifespan, because I'm situated at Rhode Island Hospital, but we also have to get one from Brown and from the Rhode Island Department of Health at the same time and work through those data use agreements. And I can say from the state administrative database, data access level, it's a lot easier actually to get state data than it is to get health center data, because we also work on combining those state administrative databases with health center data. And so right now we're actually working through the process of getting hospital data to then link with the administrative data. And that's a whole nother data element, because you're moving information between institutions with PHI in order to have data linkages. So the legal portion, the data use agreements, and making sure that you're kind of following every step necessary to maintain that sensitive data. But it's also a great opportunity to do the linkages.
I think what I heard from Dr. Wightman and Dr. Woodswell answering both the first and the second question is also just how important it is to know the data set. So I think whenever you are accessing a data set that isn't yours, or you're getting from another source. Before I came to ASTO, I used to work as a prescription drug monitoring program epidemiologist. And when people did use that database for research, I also spent a lot of time talking with them initially about what the data did and didn't say, and some of the limitations of the data too, so that was understood as well. So I think if you're able to have that conversation with the owner of the data or someone very familiar with the data set, it's going to be a big advantage to the research too.
So in a similar line of thinking about data and data access, can anyone access the HEAL data platform and the HEAL semantic search engine? And Liezl, I will pass this one to you first.
Yes, absolutely. The HEAL data platform and the HEAL semantic search engine are open for everyone to access. What's especially noteworthy is the platform's capability to provide rich information based on the metadata that we've received. And so even when the actual data isn't available for sharing or requires specific approvals, using these tools can help you pinpoint the studies that do have the data type you're looking for. And it's remarkable how the ecosystem can furnish such comprehensive details, ensuring that our users gain meaningful insights even when the data access is limited.
So the next question that came in is that data sharing and making publications immediately available are two clear routes to open science, especially in the academic realm. How is Connections team taking these actions one step further? And Jenny Cook, I'll let you start.
I feel like that was a softball somebody threw to me. But yeah, right. I think that open science in academia is great. Just because it's in an open journal does not mean that that's necessarily accessible to a community partner who might not understand the jargon or the technicalities of what you're talking about, or how to read a journal article at all. So the idea of HEAL Connections is bringing this data alive to stakeholders that are far outside the orbit of academia and conference presentations and journals and data sets and things like that. So yes, making the source material available to everyone is great, but I think Connections, it's in our name, we're also trying to connect and translate that information for a wide variety of stakeholders, because everyone is impacted by the research that we do, and they all have a right to access this information in formats and language that they can understand.
Thank you. The next question will be addressed to Jen Farfalla. What role does current research in the field play in public health overdose prevention efforts?
Sure, thank you. Well, I think, at health agencies, there's a constant finger on the pulse of what the current research is, and there's definitely a desire to be innovative while also being evidence-based with prevention efforts, especially for overdose. So I think a lot of times the science teams at health agencies will see new research, and that might lead to looking into if that is going to pertain to their jurisdiction. Maybe it's something around how to drive naloxone distribution into communities, or reduce stigma around people who use drugs in health systems. And I think something that I've seen be particularly important, and that we saw highlighted here today in Dr. Wightman's relationship with the Rhode Island Department of Health, is that when health agencies have a partnership with an academic institution that is doing this research, it makes it much easier to access, easier to understand. You can talk with the actual researchers. So there are health agencies all over the country that have these types of relationships, and I think those are really building a bridge to getting the current research into actual public health practice, particularly around overdose prevention.
Thanks so much. I'm just going to add to that, just based on, I can give an example of what we're doing currently at Rhode Island Department of Health. So using 48-hour reporting for overdoses from EMS and emergency departments, there's an ongoing drug overdose surveillance system that has set thresholds, and it's updated. They just changed the updating time to be a shorter period of time, actually, to have kind of faster data dissemination. And when there's a certain number of overdoses per population in a given region, it hits a switch to send out communications, and it also promotes our outreach teams to go to those different areas and start reaching out to community contacts and bring supports, bring resources to those areas. So just an example of kind of like a working data dissemination system that's tied with action.
Thank you for your responses. So in sort of that idea of looking at research findings, how does the Connections team identify research findings to share?
That's a fantastic question. We are doing that in a number of ways. Sometimes folks come directly to us. We have been scheduling a number of get to know you meetings with people. We are also scanning literature constantly, working with the data stewards, looking for those things, those projects that are ready for dissemination. But I think the more important thing is for everyone watching today to know that you can reach out to us at any time. We can put our email address in the chat if it's not already there. We are ready and available to brainstorm with any project for an hour and help you think through a dissemination or an engagement strategy. If you decided that you wanted deeper support, we then would go work with the NIH leadership that works with you and figure out a strategy. And I see someone just put that in the chat. So please do, if you are interested in dissemination support, please do reach out to us.
So one final question that has come in is, are there any thoughts from the presenters on reconciling the need to know data with the principles of making data fair, which sometimes includes either machine actionability with as little intervention as possible?
I can take a stab at this. I'm not really entirely sure if I understand the question entirely, but we we receive data dictionaries from studies, and that's how we're able to semantically connect various concepts or biomedical concepts. And the HEAL team does have a common data elements program that try or in an effort to standardize these collection methods and processes. But I'm not entirely sure if that answers the question. We do conduct the semantic linkage manually and using automated processes. Right now, the data dictionaries we receive are not standardized, so there is a lot of work involved in harmonizing different data dictionaries in terms of connecting biomedical concepts. And if anyone would like to jump in, please feel free.
So I would like to thank our presenters, Dr. Jessica Mazerik, Dr. Sarah Woods, Dr. Rachel Wightman, Liezl Foss, and Jennifer Cook, as well as our Q&A guest, Jennifer Farfalla. We're grateful for your insights. If you could go to the closing slides, there are resources listed here and that are located in the chat for you to take advantage of support that's offered by each of these teams. So if there are questions that you have that we were not able to address, we're more than happy to make contact with you and help you work through questions around publications or other issues around data reading, machinability, and administrative data. If you could go to the next slide. In addition to our presenters and panelists, we would like to acknowledge the behind-the-scenes team listed here who worked diligently to bring this webinar to production. Next slide, please. And we would like to thank you, the audience, for your participation in today's webinar. We hope that you are leaving with a better understanding of open science and the HEAL data ecosystem resources available to help you succeed in meaningful data sharing. In addition to a recording of this webinar, we will also email everyone who has registered a list of resources. This slide deck will be shared, and a link to our Slack channel and Connect with Us form are located in the chat. We hope that you will reach out to the HEAL data platform, the HEAL Stewards, and the HEAL Connections team for any questions or support that you need as you embark on your FAIR journey to maximize the value of HEAL data. We look forward to seeing you at our next webinar on Thursday, January 18th at 1 p.m. Eastern Time, where we will focus on sharing sensitive data. Thank you again, and have a wonderful afternoon, everyone.